Hey, welcome back to the Health Bridge. Dr. Pedram Shojai here with a special guest, Dr. Raj Dasgupta, who's a clinical professor of sleep medicine over at USC. So local and welcome.
Thank you very much for having me here.
Yeah,
Thank you very much.
Great to have you here. So sleep is near and dear to my heart, A, because I don't get any. We got a 1-month-old kid at home, and so it's gonna be, I'm gonna game the show here to get some personal help from you here, because it's been rough. Sleep is also near and dear because I used to be in the business. I used to very much follow what sleep was doing because the good stuff that happens in sleep we take for granted.
Yes, we do.
Right. So so you are pulmonology, internal medicine. What else? You've done like 9 board
Critical care.
Critical care.
I think that's about it right there.
Yeah, and you spend a lot of time traveling and teaching. So,
I do.
I swam upstream to get to the top so that we could make sure we get the right answers for y'all today. So, what got you into sleep in the first place? I mean, it's esoteric in some ways, right?
Well, I think 2 things. Number one is that, I finished pulmonary, and that's about the lungs and asthma and COPD, but there is one sleep disorder that seems to get a lot of attention. That's going to be sleep apnea. And that's going to be, apnea is defined as no flow of air, no oxygen in, no carbon dioxide out. And it kind of made sense that, hey, you know what? Breathing at night, breathing during the day, maybe I should combine the 2 worlds. So my initial, when I first went into sleep, was to kind of like bridge that gap between pulmonary and sleep apnea. But I realized soon after that there's a lot more to sleep than just sleep apnea. Insomnia, narcolepsy, sleepwalking, I could go on with it. So I definitely want to give a message out to everyone that it's not you're going to see me only because, hey, my husband snores, but there's more to sleep than just that. And that's why I'm so excited to share this with you. Great.
Yeah. So there's a lot there. So I think the smoking gun, the ones that like cause all these problems, like apnea, is because people die, right? Like people fall over and die. They get cardiac events.
And there's always a joke I say, because someone always, with sleep, it's so hard. I always make a joke that, what's the easiest medical disorder to treat per se? Acne. You treat it, you're gonna look better, everyone follows your orders. But when it's sleep apnea, nothing's gonna happen just right away, like diabetes and hypertension. It adds up. But I always tell my patients, what's the worst thing that can happen to you with sleep apnea? Car accident, death. So you do have acute problems. But of course, long term, like you said appropriately, it leads into diabetes, which is actually the deadliest risk factor for heart disease. It leads to hypertension, which is the most common risk factor for heart disease. And in our country, around the world, heart attack and stroke are killers.
That's it. That's it. And so what percentage of people do you guys obviously have these numbers. What percentage of the population have sleep apnea? Is it huge or?
Yeah, I mean, I might just blow you away by this, but 15 million people. So of course, when you talk about definitions, it depends how you define it. So if you're talking about actually just I have snoring, or based upon what the cutoff level is for mild, moderate, severe, you can make that number very big or very small. But 15 million is quite a bit of people that have this, and this is why I'm very proud to say that we're doing a really good job in our country about diagnosing it, because it's more than just coming to the sleep lab and making the diagnosis. There's home sleep testing took over, and now you really have to twist my arm to say that you can't get diagnosed if you suspect it in certain individuals. It's for everyone now to make that right diagnosis.
Just to catch everyone up and make sure we're on the same page.
Sure.
Sleep apnea is oxygen to the brain. You have obstructive, which is kind of windpipe. Basically, the plumbing ain't working.
Right.
Versus central, which is a nervous system thing. So let's just define that real quick, just so we're all on page.
All right. So when we talk about obstructive apnea, the word apnea means no flow. No flow of air, oxygen in, carbon dioxide out. But the biggest misnomer is this is not the obstruction here in the gut. It's around the neck. It's going to be posterior pharynx, your tonsils, your uvula. That's where the obstruction is. So when you have an obstructive apnea, you're having a lot of effort to breathe, but because of the obstruction, you can't get the air in and out. And you know how long you have to be to consider an apnea? 10 seconds. It's quite a long time. So that's going to be the most common type. When we talk about central apneas, well, these are ones where there's just no effort to breathe in itself. And usually when we have central apneas, they could be from drugs, such as things like methadone and opioids and Vicodin, because they suppress the respiratory drive. Or there's problems in 2 organs in the body. The brain, so maybe you had a stroke or a disease like multiple sclerosis. Or the big one is the heart. And when you have heart failure, like congestive heart failure, and you have the central sleep apnea pattern, It's actually a very unique name. Now, I'm going to get geeky, so I apologize.
Please do.
It's called Sheen-Stokes respiration. And if you have heart failure plus that, oh boy, that's a bad recipe. But I love what you said. The reason why we need these sleep studies is the treatment for central and obstructives are totally different. Excellent statement.
Well, and so the good news, which you'd already alluded to, is that most of your kind of frontline docs know how to screen for sleep apnea. And if they suspect it, now there's home tests and sleep labs.
Yes, yes, definitely. And I think that there's many questionnaires out there. And the one that we use quite commonly is called the Stop Bang questionnaire. And each of those is going to be representing a letter to represent something like hypertension. Do you snore? Do you have a thick neck circumference? So there's no excuse to have a good screening tool when you suspect individuals to come there. And when we talk about sleeping, it's such a big part of our lives. You know, we talk about how the essentials for good eating, good drinking, and breathing, sleeping should go right up there. So whether we're talking about sleep apnea in itself, which of course is the big one when we talk about pathology, there should be other things we should think about too as primary care physicians. And just leads into my next statement, which is insomnia.
So last I checked, it was 62% of the American population. It seems like everybody. Like, who the hell's sleeping? Right. So what's happening with insomnia? Why do you think it's so high? And how do we got to look at this to start resolving it?
So before I answer that, I just want to give a blanket statement about sleep. So sleep deprivation is a big thing in society right now. And in fact, I just recently did an interview about the millennials and sleep deprivation. So it shouldn't surprise you that our total sleep time in the 70s was around 7 to 8 hours, which is great. That is the appropriate amount of sleep we hope to get, though sleep is individualized. But when they were polling in 2015, what's the average total sleep time? It's around 6 to 7 hours. And let's say we tack on another 40 to 50 years, who knows the way the trend is going? What's going to be the normal now? Is it going to be 5 to 6 hours? So the thing is that when you ask me why are people getting less and less sleep, it's because of the foundation of the things that we brought up, the mottos we were brought up with. I could sleep when I'm dead. The early bird gets the worm. You know what someone told me the other day? I thought it was kind of interesting. He said that, sleep is a poor substitute for caffeine. I'm like, okay. So if those are the type of phrases that we've grown up with, it's not surprising that when we talk about millennials, which was what this person was asking me about, is that because of how tough jobs are, because of technology, because of iPhones and iPads and all this, of course, it's going to be harder to go to sleep. It's going to be hard to get good sleep. Insomnia is so prevalent. So to answer your question is that I agree. I think everyone in this room, everyone watching us has had transient insomnia at some point, but it all depends on how you categorize it. Some people have chronic insomnia, some are acute. It all depends on how long you had the symptoms for.
Well, so, I got a baby at home, so, you get a wailing baby, you're waking up, right?
Yes.
But let's get into general sleep hygiene quickly, because I think that is something that isn't quite taught in school. And, there's some kind of general do's and don'ts that make sense, right?
Well, I would say the main thing is always going to be that you want to transition into sleep. Meaning that, you want to have a room that's going to be on the darker side, on the cooler side. And just to kind of go on a tangent right there is that temperature is going to be key. And everyone has this, I just did another interview where they're talking about sleep during the wintertime. Great topic. So I think the old adage of, it's cold outside, you know what I mean? And it's going to be, darker, it will be a recipe for good sleep. It's not. So actually, having temperature during wintertime means that sure, it's cold outside, you have the heater going, but it can dry up your upper airways. When you dry up your nose when you wake up in the morning, that predisposes you to snoring at night. And on top of that, when you have a dry nasal passage, you're predisposed to infections, especially during wintertime. So it's not all that it's cracked up to be. And what happens is that, in general, yes, that when you go to bed, you want your body to be on the cooler side, a little bit below body temperature, a little bit, because when you warm up, when you wake up, you warm up, and when you lay down, you cool down. But it's such the extreme during wintertime in itself.
Interesting. So they say cold head, warm body is kind of an old, old saying, right? But
I can see that,
so we can say that maybe more comforters, less heater, get a humidifier. Like, what are a couple hacks?
I think it's very individualized, but definitely you don't want to underestimate just drying out the upper airways, and also during the holidays and winter season. Oh my, you can just imagine the food that we're going to be eating, and that's a huge part about good sleep hygiene, which is going to be when to eat, when to drink, and good sleep hygiene says you don't want to eat or drink too close to bed. Number one, you just could get heartburn in general. And number two, of course, if you're drinking a lot of liquids, you're going to have frequent trips to the bathroom. Then on top of that, you can imagine during the Thanksgiving, Christmas, New Year's, it's going to be a lot of just carbohydrates and fatty foods, and that's going to tip you over to have increasing your body mass and be predisposed to sleep apnea. So all those things are going to be factoring in there. And let me just say this, is that when we talk about drinking, what about the patients that say, I need that glass of wine before going to bed. I need that alcohol. So don't get me wrong, if you want to get knocked out, drink the alcohol. But what's the downside of it is the multiple awakenings that occur when drinking alcohol sometimes.
So it knocks you out, but then you don't get the quality sleep that night.
Yeah, you get those frequent awakenings. Yeah. So it's kind of like it's a fool's gold. You know what I mean?
Sure.
Exactly. So we don't encourage that.
Yeah, it's like swiping something on a credit card that you can't afford, right?
Yeah.
Down the line, you're in trouble.
And I'll tell you one more thing. Some of my patients, even if I'm wearing a T-shirt that says the word pulmonologist on it, they'll say, Dr. Raj, I need that cigarette before going to bed. I'm like, you got to be kidding me. Number one, smoking bad. Number two,
stimulant.
It's a stimulant. So when people tell you they need to have that I don't think that's a good idea right there. But I think a couple of the key things that all of us go through, number one, if you're having insomnia, things not to do is TV in the bedroom, iPad in the bedroom. And it's really sad, especially when we talk about the millennials, you know what I mean? They have almost that, they did a study that shows that 80% of millennials will be an arm's distance of their phone when they go to bed. They almost have, they're waiting for that notification of their Facebook, of their Twitter, and they have this kind of like Pavlovian response just to grab it. So the key thing is that if you're having difficulty sleeping, definitely no TV, no iPad, those things in the bedroom. And the teaching points will be twofold. Number one, yes, the light they emit from these devices will suppress melatonin, which is a natural hormone in your body, but it doesn't transition you into sleep. And depending upon what you watch, that could really stimulate you to not get sleep. And things that I don't encourage watching at night, the news. There's nothing more stressful than watching the news nowadays.
Yeah, nowadays especially.
Exactly. So there's certain things, and also clock watching. When I have a patient that says, hey, Dr. Raj, I'm waking up every night around 3:15, then again at 5:23, I'm like, wait a minute. You shouldn't be clock watching. Have an alarm. Go to work on time. But what happens is, let me talk about myself. I have to start my day around 6 or so. I don't know why. Every day around 5:30, my body wakes up. I got to go to the bathroom. And if I look at the clock, I'm like, 45:30, what's the point? But if you don't know, you're just going to leave, go through your day as if, hey, I got that good sleep. It helps out mentally.
Yep. So there's one thing that I think we're all kind of guilty of to a certain extent, which is borrowing from tomorrow's energy for today.
Right.
So what's your line on caffeine? If someone has insomnia, I've heard 2 o'clock, I've heard noon. At what point do you need to stop so the half-life of this crack is out of your system so you can sleep right?
No, I agree. It's just amazing. When we talk about how people start their day, no matter what they're doing, they'll end up at their Starbucks first. They'll go to their corner of Starbucks to have that. So I agree that you want to drink caffeine products earlier in the day, but it depends on who you are. If you're not having any sleep problems, then I'm not talking about you in particular. But of course, you want to watch out with these stimulants. And I would say another thing, in this day and age, it's amazing how people are more open to being on certain medications just to give them that oomph. Even prescription medications. The one I want to talk about, and I'm going to be geeky, so I apologize, is something called modafinil. And it goes by the brand name Provigil. And this was initially a medication that was meant for a disease known as narcolepsy. But because it's an awareness promoter, you'll be surprised how many professionals who just want to get that extra step ahead will be very open to being on medications like this. So I think that good sleep hygiene says, yes, avoid caffeine closer to nighttime, and definitely earlier to the morning is going to be the better. But it's just amazing the turn our society is getting. They're definitely more open to it than before.
Well, man, I have a number of friends who party on Provig.
Professionals.
You've
heard of it then.
Professionals that are using this all the time.
Yes.
What's just as a quick aside, what's your take on nootropics and the racetam family? I don't know if you've ever had exposure to I have a lot of professionals that also take those daily.
Well, the big thing is that if anyone is going to be taking natural supplement, herbal supplement, I think I always say tell your physician what you're taking because of the drug-drug interactions. And on top of that, not going towards the stimulant side of what's going on, but just taking a step back and saying, I see more of the insomnia side. And you'll be surprised what people take that actually will be over the counter, they don't tell me, for their insomnia. So, number one, maybe you heard of valerian root, kava, all these different things, and they all have their side effects that they're not used to. And the only one I want to make a note of is the one that is actually very, very toxic to the liver for insomnia, and it's going to be kava kava. It's a big thing that people will have. They go to like tropical islands like Fiji, they'll drink it, but it's very liver toxic, and especially because it's toxic to the liver, if you mix it with alcohol, you could only imagine what that's going to do. So to answer your question specifically, I am familiar with it. I don't encourage it because of the fact that, number one, what dose are you going to take? You don't know because it wasn't studied that way. Exactly. Yeah. So even the benign things such as melatonin, you know what? I know many people are on it. It's not that benign. So I would definitely let your physician know everything that you're taking.
What I've seen with melatonin that has been more promising than insomnia is some of the jet lag research where you take 5 mils. It's like, okay, for jet lag, you can hack into it, whatever, but if you're taking melatonin every night, that seems like it's a challenge. So I want to talk about something philosophically right now, because you mentioned it kind of in passing, and I want to kind of hammer this home.
Sure.
Is this use of stimulants and this psychological crutch that we need to keep kind of cranking on the dial to turn it up. This is the very thing that sleep is supposed to balance, right? Like, so we're supposed to go down so we could come back up in a balanced way, and we're all just trying to like turn up the heat. So what does sleep do that's so valuable? And I really want to paint a picture for the value of this stuff, because I think culturally it's lost its place.
Right, you know, it has. No, I would say we could go through all the different aspects. I think number one, I'll say it once again, the health aspects, is that sleep is essential. It's very important for preventing hypertension, which is high blood pressure. We mentioned about the diabetes, and you're gonna ask why. So the reason being is that if you're having multiple arousals during the night, if you're staying awake, if you're sleep deprived, there's certain stress hormones in our body that get released. And the big culprit's always cortisol. And when you have higher levels of that, cortisol will actually increase your blood pressure. And when you have high blood pressures in the vessels, that means that your heart is having a harder time to left ventricle pumping into the circulation. You'll lead to what's called left ventricular hypertrophy, which is a form of heart disease, a cardiomyopathy. And that's why, you know, people don't realize just by being sleep deprived puts you at a higher risk. And also, when you have high levels of many stress hormones, what happens to your blood sugar, the glucose? It goes up. So by far, many medical reasons. But on the other side, there's many cognitive reasons. So when we go to bed, there's definitely certain parts of sleep that we want to get into. When we're younger, we like to go into N3 sleep, otherwise known as delta sleep or slow wave sleep, because when we're kids, it releases a very special hormone known as growth hormone. And that's why our parents always told us, get good sleep at night. But then, you know, around every 90 minutes or so, you'll cycle into what's called REM sleep. That's a very important stage of sleep to help out with memory, consolidation, and it just helps you relax. And the problem is when you have diseases like sleep apnea, insomnia, many diseases, because you're having excessive arousals during the night. When I mean arousals, I don't mean you have to wake up and talk. I just mean before you go to the deeper stage, something causes you to go back to a lighter stage, and you don't get the refreshing sleep. And that's a big problem. And that's why when you talk about just safety, when you talk about injuries at work, injuries on the job, I mean, it's really highly associated when we talk about sleep deprivation. And I think the eye-opener where everyone starts paying attention is that there have been studies talking about, you know, blood alcohol level and sleep deprivation. And the scary part is that if you were to stay up for 24 hours, just having one beer is almost like having a six-pack. You know what I mean? So I think, and when you talk about, you know, some of the main things of unintentional accidents and deaths in our country, driving. It's always going to be motor vehicle accident number one. And I'm sure a lot of that gets compared to being sleep deprived. So it is very, very important.
This morning on NPR, there was a story where there was a group of physicians in India that were looking at sleep habits, and then they started to kind of cross over and look at financial decision making amongst the people that lived on the streets.
Right.
And as they started to get quality sleep, all of a sudden you saw people making better decisions, right? So it also actually hit you in the pocketbook, right?
And you know, it's amazing how they carry this base information to other aspects. So, you know, I teach at USC, and contrary to a lot of beliefs, I love our football team. I love our sports program. I wish them all the best. We had a tough loss the other day, but it's a priority. And the reason why I say about this is that a lot of other professional teams and collegiate teams have actually made sleep an issue, an importance. I know in some professional baseball teams, they have a napping room. Yeah. And it's just amazing how they encourage this in our athletes. And nowadays, we're trying to monitor sleep, even if it's not even a professional athlete, just us. It's such a hot topic. I mean, how many times would you look around the room and someone's wearing a device around their wrist to say, hey, how many steps they took that day or how much sleep they have at night? So I'm not saying they're all accurate. I'm not saying they're all going to be the ones you need, but you could see the importance that society stresses on trying to get that sleep.
I think wearables has changed the game. Are there any in particular? And I don't want you to go brand endorsing or anything, right?
Right.
You heard it from here. USC officially endorses Fitbit, right?
I open my shirt up. There's right here. No.
State your sponsorships, right? So, I use this thing. It's kind of cute. It's an Apple Watch. It does a few things. I don't use it to the level that I should. Right. But how can someone a regular person who knows that their sleep quality is kind of having ups and downs and dips, use this type of technology to help them?
Sure.
And what else can we?
Well, I would say this. I was asked by a big magazine, what do you think about it in general? I took a deep breath and I said, well, my answer is this. In any device where the two main purposes behind it is to exercise more and to get better sleep, well, I got to be pro. I gave 2 thumbs up. I believe in that. But the key thing is that a lot of these are not going to be prescription devices that have the studies to prove it. So I would say this is that we do use a device known as actigraphy. So actigraphy rhymes with the word activity. So it's an activity monitor. You wear it on your wrist, sometimes in pediatrics on the ankle, and it has an algorithm that says, hey, if you're moving a lot, you're probably not sleeping. And if you're not moving to a certain amount, then they could translate that into sleep. And the one thing I do like about that, it gives you a rough estimate of your total sleep time. It's not gonna, I have some devices saying, we'll tell you're in N1 sleep, then N2, and here's your REM. I'm like, wow. That's a little more than I think you could tell me, but I like it just tell me what is my total sleep time. And the reason why I like it, especially actigraphy, which is FDA approved, is that once in a while I'll always have a certain type of insomnia known as paradoxical insomnia. So what does that mean? The patient will come to me and look at me right in the eye and say, Dr. Raj? I'm like, yes, I haven't slept in 4 months. I'm like, no, you'd be dead.
Right.
But, I make them wear the activity for 2 weeks, kind of get a good estimate, and you'd be surprised how people misinterpret how much they're actually sleeping. So there is benefit from it. But one of the devices I thought was kind of nice, there's actually, I believe it's an app. And what you do is you take the phone, you sleep under your pillow with it, and based upon movement and different types of algorithms, it's going to wake you up during the lightest stages of sleep. What do I mean by that? So, if we talk about naps, you know what I mean? How many times has anyone taken a nap and they wake up and they feel worse than they did before they nap, And so the key thing about that is a nap should be about 20 minutes, waking up in the lighter stages of sleep. Once you start going to N3 or REM sleep, that's when you get this thing called sleep inertia, where it's like, oh, I feel horrible. So I thought it was kind of unique that they're taking some science, trying to put it into some technology where, hey, if you're in what we call N1, N2 sleep, it'll do something to wake you up. Kind of interesting. Another technology that came out, it just, was kind of interesting. I was, doing a little research. There's a new device out there that you place it by the bedstand. I believe it's called a NOR, N-O-R-A, or the NORA. And what it does is kind of sense that there's going to be some snoring. And hopefully before you wake up your bed partner, it's connected to a device underneath your pillow to help extend the airway to prevent the collapse. So it's not like an FDA-approved device, but it's just amazing how so many people are coming up with new things to help out. And let's see where this pans out.
That's awesome.
Yeah.
So short of a 32 lead EEG, we're not going to know someone's in stage N3.
Right.
It used to be called stage 4 back when I was in the biz, but
you caught that. So before it used to be stage 1, 2, 3, 4. Stage 3 and 4 got turned into N3, and N stands for non-REM. You got it. Yep.
So non-REM
scoring
sleep,
system.
and then
Exactly.
and then REM was before that.
Yeah.
Kind of pop the clutch and go in and out.
You know your stuff.
I used to know a few things, right? It's just fascinating to me.
Yep.
And I have a bunch of friends in the neurofeedback world that have been actually training Delta and trying to get people to calm down and be able to do it. It's really hard.
It is.
There's all these people that are like, oh yeah, you do train Delta, you're going to be able to pop in. No. There's like this deceleration, like the brain doesn't want to just suddenly slam on the brakes.
I agree.
And it's kind of wild, wild west, to tell you the truth.
And you just already listed one of the hot topics in sleep medicine, which is, when we do EEGs, there is nothing has been shown that if you treat the EEG separate from the patient, just EEG, that you get better outcomes. If someone says they're having symptoms, you treat the symptoms. But that's the hot topic. If you, change or have interventions to change your sleep stages or give you more N3 or whatnot, it hasn't shown yet. So that's a really hot topic in medicine now of what we can do.
Yeah, and it's really fascinating.
It
because
is.
You have data in front of you, and then you have symptom questionnaires, and people know if they've slept. But
of course.
Yeah. So I think that the field of sleep, despite the fact that it's not that exciting because all we want to do is go, right, is actually the promise of where a lot of healthcare kind of fixes can be found. Right?
Yes.
Obviously, you've devoted your life to this.
Of course.
And it's just the recovery. You look at peak performance. You look at a lot of the pro athletes have been in a lot of these studies, right? So have executives. And it turns out the more they rest, the more they recover, the better their performance. I'd love for you to speak to that a little.
Oh, definitely. Well, I think they kind of stirred the pot recently. I know there was an interview with Donald Trump where he made a statement that how many hours he sleeps a night, which is a very limited amount. And I think this kind of set a precedent that, hey, sleeping less is great, and that's not the case. And many and I'm glad you mentioned athletes. They've interviewed people from Usain Bolt, with all his Olympic medals, to LeBron James. Everyone really makes a big push to say that sleep is a very important part of their regimen. And speaking from the athletic side, it's clearly been shown that, if you're an athlete, the chance of getting injury is much less. Why? Because of the fact that you're probably a little more astute, a little more careful. Your reaction times are better. Can you imagine being on the court hitting that last second three-pointer, So all these things have really, really factored in when we talked about, the importance of good sleep. And like we said, they're making changes like napping rooms, having PI, and I remember that in one of the Olympics, they actually had a sleep doctor work with how to make the Olympic facility to get the perfect types of, the light and the dark and the timing. So it's definitely factoring quite a bit. I also wanted to make a point that, when we talk about some of the more exciting parts about sleep that we get to talk about, it always seems to be what we call these parasomnias. And I think that it's not the most common thing we see, but what are examples of parasomnias? I mean, these are these unwanted behaviors and actions that happen sometimes. And the classic example is sleepwalking. And I think when you start talking about those parasomnias, all of a sudden everyone's like, oh my God, and it gets that attention, that press and everything like that. So those are I think the topics that may not be as common, but if you want to know what are going to be the ones that always catch people's attention, it's going to be those kind of stories.
Sure.
Yeah.
Sure. What percentage of people have those, like sleepwalking, sleep talking? Is it a large percentage of the population?
I think it goes very underdiagnosed because, I think people are sometimes a little embarrassed. And when we talk about like, why do people see me sometimes? It's going to be just as though some of their actions or at nighttime, are they normal? And the one I wanted to mention to you, have you ever had this one? Let's say you're just about to fall asleep, you had a really long day, and you're just about to doze off, and your body does this.
The jolt.
Yeah. I can't tell you how many people ask me about that. It's called a sleep start, a hypnic jerk. 100% normal. Just mean you're sleep deprived. Or how many times are you sleeping next to, here's a scary one. How about when you're just about to fall asleep, you're just about to wake up, and all of a sudden you're paralyzed and you can't move. Have you ever had that? It's called sleep paralysis. Very scary, but normal. It could be a sign of other disorders, but it's a normal variant. And the one I was talking about, sleepwalking, have you ever had it when you're next to a bed partner and all of a sudden he or she wakes up and maybe we'll say a few words, but then we'll go back to bed in the morning, you're like, hey, do you remember what you said? And you're like, no, what are you talking about? That's a parasomnia called the confusional arousal. And sometimes if you let that play out, that patient could leave the bed, could do some sleepwalking, and contrary to popular belief, you could sleepwalk with your eyes open. And sometimes that leads to sleep cooking and sleep eating. Wow. So, tomorrow, if you're not busy, you want to turn on the doctors, I'm actually going to be talking about something called nocturnal eating syndrome.
That's amazing.
Yeah, and it's going to be a syndrome, unfortunately, where, people will eat greater than 60 to 80% of their total caloric intake after dinner. And they can't go to bed unless they eat. If they wake up, they have to eat. They don't eat in the morning. And it often gets confused with something known as sleep eating, which is actually, you're not aware of it, it just happens. So kind of an interesting topic in itself.
Have these people, do they have any sort of crossover, like blood sugar issues? Do they have any like high cortisol? Like I'm fascinated about what drives
We should extend this episode.
Yeah.
I was going to say that. So excellent question, by the way. So the reason why I talked about nocturnal eating syndrome is that, number one, is that 20 million females have eating disorders in our country, 10 million males, and nocturnal eating syndrome has been associated with binge eating, has been associated with bulimia nervosa, anorexia. And because you're eating at night, like you said, high association with type 2 diabetes. So, and that's why it's like the tip of the iceberg diagnosis. And you ask me how many people will have parasomnias in general, they're just embarrassed sometimes to talk about it. So when I have patients that bring it up, it's, I'm very proud of them. It's just not easy. Sleepwalking, I just want to say two things about it, that it's more common than you think. It's associated with sleep apnea. Why? Because you're always arousing yourself at night. And I'm going to ask you a question. So you want to take a guess? What medication that's very common in the United States that we use for sleeping can result, a side effect could be sleepwalking?
I would have to say Lunesta would be my first guess.
Why are you so close? You're amazing. By the way, Ambien.
Ambien.
Yep. And it's unfortunate how we're joking about modafinil and Provigil. Everyone's on it. Come on, Ambien.
Too. I know.
I mean, you might as well put it in CVS.
Yeah.
So, and it's very associated with, and that's why if you ask me, is the prevalence of sleepwalking getting more and more? Yes, because a lot of people are taking Ambien. Unfortunately, let's go back to pharmacology, and that's what scares me, is that if you ask me how do you treat most sleep disorders, you have to say cognitive behavioral therapy. That's the foundation. But our weapons, unfortunately, are going to be stimulants on one side and sleeping aids on the other. And I think that there are certain times and certain individuals that may need it, but we can't take any shortcuts. We have to go through the cognitive behavioral therapy.
Okay, so that cognitive behavioral therapy is kind of the answer at the end of many roads in medicine, by the way. But that sounds like kind of a heavy lift. Those are big words. Let's define what that is, so that if someone who's listening to this will be like, okay, that's what I got to do, right? And it doesn't necessarily mean going to a psychologist forever, but it means modifying behavior. So
number one, if you do what we call CBT, cognitive behavioral therapy, it's not an overnight fix. And that's why when someone comes to me after they've been waiting months to get the appointment and I say, hey, here's your CBT, it's not the expectations they wanted from the visit.
I kind of wanted a drug, Doc.
I know. And you're definitely going to feel worse before you feel better. And it takes around 2-3 months to change the way you think and behaviors. So cognition is the way you think, behaviors are literally your behaviors. The two things I want to mention during this show is, number one, sleep restriction and stimulus control. This is the foundation of behavioral therapy. Sleep restriction means a set bedtime and a set wake time. Just because it's the weekend doesn't mean sleep in late, so you want to be consistent with that. When we talk about stimulus control, contrary to popular belief, the bed is only meant for one thing, sleeping. And if you're in bed and you're not sleeping within the first 15 to 20 minutes, leave the bed. And when you leave the bed, do things that are non-stimulating in dim light. It doesn't mean to go online gaming. It means read a book, not on your iPad, an old-fashioned book in dim light. So that's going to be the foundation. Cognition is the way we think. And there are many different things we do. And you mentioned a very important thing that's called biofeedback. And biofeedback is not something we do very common clinically, more in the research setting, but it's like you said, you do some imagery, some guided imagery. You want to kind of bring down the heart rate. In some institutions, we'll actually do what's called a galvanic skin response. This is pretty geeky, but we'll actually put like pads on the skin to kind of measure sweat response. Because if you are very excited, a big sympathetic surge, you'll sweat more. And if you're very relaxed, you sweat less. It's the foundation of a lie detector test. But one of the things that we do if we have time is going to be what we call worry time. And why worry time with people with insomnia is because stress is a huge part of insomnia. And the time we think the most is always going to be in bed. So, not to belabor the point, but what worry time is similar to study time. You pick a time during a day where, not in the bed, not at night, where you go and you kind of write down the things that that worry you, that bug you. Not to dwell on it, but how to come up with solutions. And you want to divide this list simply into things that you're in control of and things that you're not in control of. Because, for example, can a meteor hit planet Earth tomorrow and we'll all be passed away? Of course. Can you control that? No. But can you control turning your TV off? Yes. So you make a list and you prioritize. So these are the foundations. That's not an overnight fix, but recent research have shown that CBT can work in the acute setting and has already been proven to be long-term on these diseases.
Great.
Yep.
So we're taking this bag of worry
Yep.
into bed, and we don't have the right hygiene, we don't have the right practices to actually be able to sedate ourselves into sleep.
Exactly.
And that's the big problem here.
It's 100% the big problem.
So I love this because it's very in line with just good, clean, healthy living. And at the same time, I mean, I would assume at least 60% of the people that are sitting there worrying about stuff is some sort of financial, some sort of like, kind of life crisis thing. We just have a lot of stress.
Unless you're Donald Trump.
Unless you're Donald Trump.
Then you're not worrying about
Then you're worried about Mexicans, right?
Yes, but on top of that, especially during the holidays, I was going to say, one topic you may want to avoid a little bit during the holidays, family. I mean, bless them, but it's always going to be something that's not going to give you that good sleep, you know?
Well, and family brings drama, as does everything else.
Exactly.
So I love this subject because I love sleep. Oh, God, do I love sleep. And I got a baby at home right now. We have a one that's almost 2 years old. We got one that's just over a month old.
Wow.
And so, I mean, talk about like sleep arousal and all these types of issues. Is one wakes up, the other cries. And so sometimes we wake up in that kind of perplexed state where we're not in that light sleep. And so then it's hard. Like, when you wake up on the wrong side of the bed, so to speak,
right.
How can you kind of hack your physiology to kind of get back in step? Because I know people who do this that are just stumbling all day.
No, definitely. Well, first off, congratulations.
Thank you.
You are blessed, you know what I mean? And let me just say from experience, because I'm a father of two, it doesn't last forever. There is a golden light there. And the hardest part is, when you have a newborn, is that the awakening, it's a necessity. It's for feeding, it's for eating. So I think we all going to have that tough patch. I think when it gets tough is when you hit when you start becoming a toddler and it's going to be that first and second year of life, it's going to be hard because of the fact that there are so many great advice. But you know what? We all have different living situations. All our houses, our apartments are different sizes. Easier said than done, But I would want to say for mom and dad, you know what I mean? What are things that you can do to make sure you're going to have, or at least attempt to get good sleep? You're going to laugh a little bit, exercise.
Sure.
I always think that's the first thing that goes. And I want to say, if you're going to exercise, try to do it earlier in the day. I think the key thing is, with all of us, after work, it's already 8 o'clock, and I'm gonna go to the gym and do some treadmill. But remember what we said in the beginning of our conversation? Body temperature plays a big part. And what do we have to do when we lay down?
Cool.
Oh, I love you. You should be one of my residents. I mean, I would dig it. So anyways, so when you work out, what happens to your core body temperature? It increases. It takes longer to go down. So exercise will make you sleepy. It's good for your health, because when we have insomnia, we said it's going to be a dysregulation of many hormones, not just cortisol, melatonin, weight hormones. Leptin and ghrelin will be dysregulated. So exercise is going to be very important. Also, on the same token, eat smart and eat a good breakfast. I think, I mentioned really briefly about this nocturnal eating syndrome and other disorders. Don't be the person that's just, I'm so in a hurry, I'm not gonna have breakfast, I'm just gonna have a small lunch, and you just are setting yourself up to a lot of nighttime eating. And we said good sleep hygiene means not eating before you go to bed. So diet, exercise is definitely gonna be the foundation. So when we talk about diabetes in the olden days, that there was this mentality that what happens when your blood sugar is very, very low in the morning? You know what I mean? So it's going to be very tricky, because sometimes what happens is that if you wake up in the morning and your blood sugar is high, well, it could be high because you're poorly controlled, and maybe you have to do something with your diabetic regimen. But the thing that's scary is that, well, maybe your blood sugar was actually high in the morning because of the fact that it was too low at night. And when it becomes too low at night, you could die from hypoglycemia. And a lot of these counter-regulatory hormones kick in, and the way these patients present at night could be nightmares, sweating at night. So the answer is that, be careful. Get a good log about checking your blood sugars, and that just because you have high blood sugars in the morning doesn't mean just crank up the insulin, crank up the diabetic control. Talk to your doctor, find out what is going to be the problem there. But by far, when we talk about sleep apnea, which is always going to be number one, of course, insomnia, sleep deprivation. I mean, many studies have shown that if you want to get your A1C just a little bit lower, you want to control your blood sugars a little bit more. I mean, treat the sleep apnea, diagnose the sleep apnea and treat it. Because like what I said, these are the arousability, these hyperarousability is going to release those stress hormones, will just increase glucose production in your body. So it's essential. Essential.
You mentioned one thing, and this is kind of my last point. I could keep you here all day, and I know you got lots of stuff to do. The fact that leptin and ghrelin are in that lineup with sleep deprivation. What does that do for someone who's trying to lose weight and for someone who's trying to manage their weight and are kind of turning every dial up and trying to just push everything, squeeze everything out of life? This part right here is kind of it's nature's kind of like last laugh in a way, right? It's like, I'm sorry, but if you don't sleep, you're screwed.
Yeah, and I'll say one thing, because maybe not everyone knows what leptin and ghrelin is. So a little mnemonic I use is that leptin begins with the letter L, lose weight. Ghrelin begins with G, gain weight. So unfortunately, when you have insomnia, the leptin is decreased, and you want the lose weight hormone. You know what goes up? The ghrelin, of course, you know what I mean? And to make it a little jovial, when you have insomnia, you can't go to bed at night, you tend to eat. And when you have insomnia, you eat at night, do my patients grab Evian water and celery? Probably not. It's gonna be those Doritos chips, you know what I mean? So by its nature, you're gonna have a bad habit, and then that cycle starts. Because you're eating bad, you gain weight. And when you gain weight, you're predisposed to what? Sleep apnea. So it's one whole cycle right there. Because many people have this feeling that the minute you're sleep deprived, the minute you have insomnia, you're going to be skinny. No, it's the opposite, and it's all interrelated. So it's very important, And on that note, I also bring up another point. Like, what are some warning signs? One warning sign I want to tell everyone is that many patients that come see me for a sleep evaluation could be as simple as falling asleep in front of the TV. You'd be amazed how people think that's just normal. Hey, I just came home, I was watching a little TV, no big deal. I just fell asleep. That could be the biggest warning sign of them all. The fact that you came home and the first thing you can do, you can't even make it to your bed and you're falling asleep in front of the TV. So of course, everyone waits for the big one, falling asleep when they're driving.
Right.
You know what I mean? That's a no-brainer. But like I said, subtle things that you may not tell your doctor or tell your wife or your loved one could be important.
Yeah, and life-changing and possibly disastrous if you don't do anything.
Exactly, no, definitely.
It's a big subject. I know that you've spent your life doing it. So you got a book coming out.
I do. So like I said, when I'm not wearing a hat where I'm at USC, which I just love, that I like to educate. So I teach United States Medical License Exam, Step 1, 2, and 3, and some internal medicine board review around the world for some really wonderful companies. And I decided finally I'm gonna have my book. It's called Medicine Morning Report. Now, don't tear up. My co-author is my wife.
Awesome.
She's a rheumatologist. And we wrote the book together. It's 60 cases, all written by subspecialists. Cardiology wrote the cardiac cases, endo, pulmonary, And it's being published by Elsevier, coming out in May 2016. And I would love to give you a copy so you could, put it on the bedstand. So when you have insomnia, you could read the book.
It's a light read.
It's a light read, exactly.
Raj, you're great.
Thank you so much.
Thanks for coming. I look forward to having you on. I'd like to tap you as kind of my resident sleep expert. This is fun.
Anytime. Thank you so much.
Thank you. And y'all let us know what you think and get us some questions. I'm always interested in this subject. It's near and dear to my heart because it's really kind of the yin for the yang of our culture. And I think you heard a lot of really good tidbits about that here. So see you in the next show.